Well, ladies and gentlemen, welcome back. It's my absolute delight to welcome Vaughan Gething, who, as you know, is the Cabinet Secretary for Health, Wellbeing and Sport. But we were here last year to hear your words, and this year with your new job, as I can put it that way, even more doubly important. Cabinet Secretary, the thing is that your job title has got the word well-being in, and that's really important to us. Simply treating illness is not the way that we want to see the way forward. You have in this room people from all sorts of disciplines that are not just industry or National Health Service. It's that total contract between the public, patients, the carers, that brings that together for both well-being and for health. So today we've spent a lot of time together trying to say, how can we put all of these elements together, not just industry and the National Health Service. And as you know from our work at the Bevan Commission, and Helen Howson's with us, trying to do that as a social contract across the patch, which I know you are very keen on. So the words co-production have been constantly part of our work today. And we've seen some really good examples, both from Wales and from outside Wales, where there's been a lot of hard work to get collaborative work together that's actually worked in delivering better epilepsy care, in delivering better anticoagulant care to prevent strokes, in delivering better lung cancer care. And these are examples where we know we can make significant advances and save money. And that really is great. So what we're going to do is distill all those down to some proposals to you that we might talk to your executive to say, how could we use those now through the initiatives that you've already got here, where these collaboratives really are pan-Wales. I mean, that's my problem in England. I find I have to talk to 10 different people. But at least here in Wales, you've got these central ways of doing that. So that's really encouraging. We heard from Andrew Goodall this morning, an open invitation to the industry to come and help him in delivering his activities in the NHS. And I've heard today from industry an equal willingness to do that in collaboration with patients and so on. So we've also heard that whereas a year or two ago industry might have been seen as a bit of an ogre, that actually there's a willingness now, certainly from the top, i.e. yourself and Andrew, to encourage the relationship between industry and partnerships. So we look forward to hearing from you.
Okay, thank you. A mini lecture here that I'll take advantage of. And you're right, I was here last year in my role as the then Deputy Minister for Health, and I've now acquired a longer title and some new responsibilities. But in many ways, the broad sweep of where we are remains, in that we still have an integrated healthcare system in Wales. 7 health boards, 3 trusts, and over our border we have a different form of system. We still have opportunities to improve on what we could and should do here in Wales to improve outcomes for patients. And what I said last year about that grown-up offer and engagement and relationship with industry to actually deliver those outcomes. And we're still in a position where, despite some loosening in the approach to the UK government, we still have the reality of less money to spend in real terms. And so there's no sign that approach is going to change anytime soon. So there are very real challenges for where we are now and where we want to be in the future. And that means that our ability to identify, support and see uptake of innovative but cost-effective and value-effective medicines is even more in demand and even more important. So I think the consistency of that part of the message is actually really important. And I hope that that's something that people in this room, whether you're from the industry, the service, or from campaigning groups, matters as well. That sometimes a change in policy isn't always welcome, because sometimes people, well, I got used to where you were, and now you've changed. We're still in broadly the same area of needing to see that transformation and improvement. That does mean collaborative working between the industry, NHS, government, and the public remains the case. And so that's about how we harness our collective expertise, how we cooperate, and then how we achieve that sustained improvement in outcomes that all of us, I'm sure, want to see. And so there's a challenge here about addressing the health needs of our citizens. And again, we know we still have significant challenges in inequality, significant risks and challenges also in outcomes in a range of conditions and indications. And it goes not just that, if you like, the high-end, really expensive treatments that get lots of the headlines. Actually, much of that is still about how we effectively use medications to deal with some of our bigger conditions as well. And at the same time, how we contribute to actually not using medication where it's not appropriate, and in persuading people to make changes to their own life choices so we don't actually ultimately need to treat. The point about well-being. So there are big system challenges. And again, another part of the consistency in our approach will be, this is about health and social care working together, and about working together not just with partners in industry around that and the independent sector and social care, but actually partners in the rest of the private and the public sector too, to really deliver for the public. Now, in the well-prepared speech I have, it talks about a long tradition of supporting evidence-based treatment, and that's true. There is a long tradition of that here in Wales. And today has been about showcasing that, about sharing, about how we collaborate and improve in the future to strengthen that evidence base. Now, that, of course, does matter. Before I go on, I just want to make another point. One of our perennial challenges is an evidence base for the future is often welcomed, but the challenge often is how our current evidence base is the right way to use different forms of treatment, whether it's medication or otherwise, doesn't always travel and doesn't always get delivered consistently. So how we want to consistently introduce new medicines, new medications, is part of where we should be, but also how we consistently use what we already have is a really big challenge as well. And the point about levelling up variation to a point which actually we're doing the right thing wherever we should be, rather than we're doing the right thing in some places and then we're doing local things elsewhere. And that's a challenge that will be for the rest of this term and beyond as well. And it shouldn't be a surprise, even in a relatively small country, 3 million plus people in a fairly complex health and care system, we shouldn't be surprised that there is variation. The challenge is recognising that and saying, is the variation justified? And if it isn't, what do we do about it? And part of the difficulty in medicine is, of course, there are often very emotive stories that come with this. And actually having that evidence base doesn't always rub up well against when someone says, I don't really care about what you say the evidence is. I'm interested in me, and I'm interested, will this give me some hope for the future? But I really think it's important from a government point of view, and equally the way that we engage with industry, that we say we're going to stick to the evidence. That's why we have appraisal processes. That's why we follow a NICE process. That's why we have our own appraisal process as well, the All Wales Medicine Strategy Group, because otherwise we get into a position where it's the biggest call, the loudest call, that gets listened to, rather than what does the evidence tell us we should be investing in. And I think that's really important from the industry's point of view as well, to understand where there's evidence, we can get alongside it. But actually, if there isn't evidence, you shouldn't come to us. And the understanding about if we think it can work, we can do something with it. But otherwise, you shouldn't be surprised it will stick to where we are. Now, we do believe that ensuring new medicines in particular, which are proven to have clinical and cost effectiveness, are available as quickly as possible and as consistently as possible. And it's been part of the call from a range of different people, not just in industry, but amongst the public and campaign groups as well. And that's why we're going to move forward with a new treatment fund, an additional £80 million over the course of this term to try and make sure that we do that. We have examples already, but these will be the newest, most innovative medicines that we can understand from the evidence will make the biggest difference to outcomes and have been recommended by NICE and the All Wales Medicine Strategy Group. So we're not going to go into a demand-led process from the old drugs fund over the border, not just because about one particular basket of treatments and indications, which I maintain it was ethically the wrong thing to do, with the right thing here in Wales. We shipped a lot of political flack for not doing that, but I still think it was the right thing to do. Now we say we've got a way to deliver those new medications across conditions with a proper evidence base. I know one of the frustrations, again, has been from different partners and actors has been in the past, is that being delivered consistently? Why do people in different parts of Wales wait longer than others where it has got an approval attached to it? Now, we envisage the new treatment fund will meet the cost of those medicines for a maximum of 12 months. So we're trying to help health boards in that first initial stage of trying to introduce new treatment, and then actually we expect to be able to plan to deliver that more consistently afterwards. And to be fair, that comes on the back of what health boards themselves have told us about that first part being the most difficult part to get those treatments available. And as I say, it will ensure this faster access to generally life-changing indications. Now, from our experience of making new high-cost treatments available, we've already done some of this in the past, of course. the previous hepatitis C treatments and indications, but also the rare genetic and progressive disease called HUS. Now, that's deliberately a series of initials because I couldn't actually pronounce the indication itself. But, there are a series of these really rare conditions that have a huge impact on either people's ability to live a life or actually whether they can live life itself as well. So we're thinking about that high impact. And, of course, in July, I announced that work was starting to establish a new fund. And that development work, I understand, is brought into relief. That points about financial forecasting and planning. And with this conference, I'm happy to indicate again that we want to make sure that information sharing takes place and allowing us to plan effectively and properly. And that means both sides of the equation having access to that information and sharing to allow effective planning to take place. I don't want us to get into the position where we have people saying, I want this medication to be available, and the service says, we haven't had the information we require from the company and the manufacturer to allow us to make an understanding about whether it should be permitted or not, whether there is enough space for it to be released, and then how we then plan to release that and deliver that through the service for the benefit of the public. Now, given the pace of which new medications do come onto the market, and now I understand there's often high acquisition costs, significant amounts of money invested into the research and developing products, I do think that the industry has a role to play in helping us to identify at the earliest possible stage the costs of introducing that new medicine, because I think it's in the industry's interest to allow us to do that. And if we're being perfectly honest, if we had earlier access to some of these indications in Wales, I can't say it'd be a bad thing in terms of the picture across the UK. So the challenge is whether it's a patient access scheme, whether it's the clinical data and information, the sooner we get to have the conversation, the better. I say we in the general sense, not suggesting that you have to sit down with me and talk about what I do and don't understand, and I'll send you to see someone else. But the earlier the conversation, the better, and the easier the planning, and the more likelihood there is that those indications will be. And equally, and just as important, I think it should be, objectively at least, although I'm not naive, the earlier people can be told no, and here is a reason why. So we don't get into that very damaging and difficult, sometimes public fallout about why some treatments aren't available in Wales or haven't been approved by NICE or the faceless AWMSG as well. Now, we welcome the ABPI's views on how industry can support the speedy and effective introduction of those new medicines, and there have been very constructive conversations around our work, and obviously the interest in the IPFR review, and I believe we're still on track to report within this calendar year, as well as the introduction of the new treatment fund. I expect to announce to how the new treatment fund will operate before the Christmas recess, and we'll be releasing the first tranche of money for this financial year in January as well. So this is all going to happen in the very near future. And in civil service terms, it might as well be tomorrow. I mean, seasons in civil service terms are often very, very stretching. And I couldn't get away with that when I was a lawyer. But I'm careful about giving commitments on timing because I want to give a commitment that is real. So Christmas recess announcement on the fund and money being released in January. Now, again, in parallel with that, I mentioned we've had a review on the individual patient funding request system. So you all know what that is. Medications aren't normally available, but there can be an exception made around that. And obviously the criteria of exceptionality is part of that. The behaviour clinicians in understanding and assessing the evidence as well and telling their patients whether that particular treatment is likely to be effective or not, what the benefit of that is, and how we plan and manage that in the system, and the points about consistency too. And again, I'm still expecting that we can have a report provided to me before the end of this calendar year. And obviously I have to then wait for what that report says and what the recommendations are. But I'm not looking to hold on to it or to try and suppress it. The report will be made available, it'll be published, and I expect to make a formal statement outlining at least the initial response to the government fairly early in the new year. I just think that if I tried to say I'll tell you what I think 3 months later, well, that'd be a farcical position to be in, and I'd much rather give an early indication of where we are and how that fits into where we want to be in the future. The helpful thing also is that because we're talking about having a report now, it allows us to have some shop again that planned into the next year of operation. Whereas if we delivered a report in March, well, effectively by then all the plans are written and coming to us to be signed off. So there's still a shot at having something to try and impact on what will then happen in the future. And I do look forward to receiving the report with the recommendations within it. And you'll know that it's been led by Andrew Blakeman. So we didn't have a clinician leading it. We had someone from and with an industry background, but someone who'd been involved in part of the NHS. He'd been involved in the NHS Blood and Transport Trust. As obviously had an understanding of how some of the service works. Are not completely new to the service, but certainly you wouldn't call him a creature of the National Health Service as well. There's been expertise around that too, and I think no one at this point has complained about the process or the people on the review. It's really nice to see what they've said, and at that point, you know how this works. There'll be people saying this is very sensible and objective, even if people disagree with it, and there'll be others who understand we won't agree with all of the messages within that report. I can't anticipate exactly what it'll say, but I can anticipate that politics will carry on as normal. And whatever happens, there'll be someone looking to blame me for what isn't being done. And that's part of the deal, though. You know, you go into government so you can make decisions. We made a decision as part of the deal to return to government to have this review. Having made that, there'll then have to be a decision made about what we do with that review as well. And I'd rather be in that position to make a choice, whether it is an imperfect choice or not, because almost every decision in government is, than to be on the outside and complaining about it. So I accept that goes with the privilege of being in government, comes with the sharper end of it as well. When I start complaining about it, it's probably time for me to move on somewhere else. Well, complain about it too much, let's be fair. You know. And of course, the patient perspective has been part of that review as well, to help inform the group's consideration of the process. So as well as having Vaughan Williams as part of the review panel, and we've also tried to make sure that the third sector been involved, but also some direct engagement with individual patients as well, who have either been part of a successful review process, but also those that haven't as well. Because I think if we just left it to having the third sector, now I'm not saying they would do a bad job, that wouldn't be fair, but people who are advocates within the third sector take a particular perspective. And having some individual patient voices as well, I think has been helpful in making sure we get a broad enough sweep to feed into the process, and I hope people will see the review as real, meaningful and independent, because that's certainly what it's intended to be. Now I know they're analysing the information, including the written evidence, and I understand ABPI took the opportunity to take part in the process as well. I'd be amazed if you didn't. But, you know, so the written evidence really is important for the review group to understand and come back with a series of recommendations for me to discuss with other political parties, to discuss with stakeholders, and then ultimately I've got responsibility to do something about them in indicating to the service what I want them to do. Now, I expect that with the establishment of the new treatment fund and the review of IPFR, key commitments from the new government, I hope people see the consistency in where we are, and I hope that's a helpful base to move forward. Because it really does be back to where we started. How do we get fast, effective and fair access to treatments that are not routinely available or not necessarily or newly approved? And that has to be part of the mission of the government, to think about the consistency of where we are. What does the evidence tell us? Where does variation exist? Can we change our systems to level out variation and to improve the fairness and the quality of access, to ultimately improve outcomes that all of us would wish to see? And that relationship that I talked about last year has to continue to develop, not just because there are potential health gains to be made, not just because there are potential economic gains to be made by a relationship with industry and other partners too, because all of it makes a difference to where we could be in Wales. We're a small country. You can get people into the same room, in a relatively small room, to try and understand what's going on and to make decisions. And we should see that as a positive advantage. Because I think theoretically, I'm not asking people to reveal their party politics, but I'd say that our structure in Wales gives us an advantage. Not having those competing interests that don't necessarily spend money well, but actually having lots and lots of different people needing to be together in the same place to make the sort of decisions we can make in Wales with 10 organisations and a government. But we need to go beyond saying, actually, that looks like a better structure. People feel better about it, saying, and now we can demonstrate that that will deliver something that you wouldn't otherwise get with a different sort of structure and organisation. It's about making real the theoretical advantage we have throughout the rest of this term in a climate of reducing money, in a climate of advancing complexity and difficulty in health challenges that we all see and exist. Where is the role of this part of our health and care system in delivering that challenge, as well as how we try and make sure that, with the greatest respect, more of our citizens don't require the intervention from industry. I still think there'll be plenty of work to go around, but more and more people who should not be having different interventions. There's something there about, if you think about the points of quality and variation as well, you should take an interest too in the role of pharmacy and polypharmacy, how we get more of that engaged and involved to understand what we really should be on. So medications you're producing aren't actually turned into something different by the time they're taken, how they're taken, or other medications as well. So there's lots and lots from a quality point of view that should make a difference to the industry too, as well as our financial and outcome challenges as well. And it's part of the joy of being in charge of a large and complex organisation, is that you can try and make progress in one area, but you have to have a mind also to what happens in a different part of that whole health and care system. But it needs a tremendous privilege to do it. And I really do think that at the end of this year, we'll look back and we'll say we've really made some difficult but necessary choices about what we're going to do. I'll set a pattern for how we move forward. And all of that, of course, will play into the parliamentary review that we're having as well. The work's just started. I think about at the end of the next year, we'll come up with recommendations from that review too, to again think about how we change and improve not just the way we deliver health and care services, but to what they are and what they're there to deliver. So I think it's still a really exciting time. For all the challenge that exists, I think we can look forward to a few weeks and say, actually, we could make a really big and positive difference. And that difference will happen if we're able to work together in a more honest and open way. And we've got those shared ambitions about improving health and care for people in Wales. Many thanks.
So thank you very much indeed. I appreciate it's a late hour, but a couple of questions. Reducing variation has been another theme today,
Yep.
and clearly we all want to do that. And I say that one of the examples we had from the commissioning group on lung cancer in Wales shows that we can do it together if we work together. That was an industry-linked practice too. And I'm pleased to see that the AWMSG has agreed the rules of engagement. So we know where the boundaries are and aren't to be there. One of the things as well, Secretary, was that we have a very rich resource here in terms of data, lots of databases. We've got the SAIL database at Swansea, but we don't necessarily have the informatics to link all this together. You mentioned the ability to interrogate data, share information on an agreed basis, anonymised whatever it may be. But I think that Wales has a unique situation here. That if we could put that together with good informatics, we'll have a magnificent database in interrogation to go for. So I'm going to be talking with your colleagues about that at Swansea.
No, happy for that to take place. We do want to take advantage of what we have. And it's about understanding the rules to start that engagement. What can be shared, how, what then happens with what comes from that, and how we then see an ultimate benefit. And it's not just, informatics should be a really big enabler, not just about the relationship between health and care services and people in the independent and industrial sector, but actually how informatics can enable improvement in the delivery of care as well. The changes that we just announced recently on access to the GP record in emergency departments and in hospital pharmacy too really should make a difference and change the nature of the conversation, because that should generate extra amounts of trust. And the trust is a really, really important currency to have. It's easy to lose, but when you have it, it allows you to do an awful lot more. There's something there about making sure when we share data, people trust that it's been used in the way that people agreed it would.
Correct.
And you can then go on and do more as well.
But the exemplar we saw on lung cancer, I'm on the Bevan Commission and Helen's here, and we have a very important exemplar meeting coming up across the road here in the Millennium Conference Centre on December the 7th, where we're picking ratings.
I think I might be there.
We're hoping you might be with us, sir. But that's where we're going to showcase some of the very best examples.
I'm afraid it'll be the end of the day again, though, just being honest. It's questions day, you see, so I can't really dip out and say I'm not allowed to answer questions today, because I'm speaking at lunch at a conference over the road. That wouldn't work.
So,
even though I might want it to.
Anybody like to just quickly ask the Secretary a question, make a comment? Please.
Oh yes, I'm from Myeloma UK, which is a patient organisation, really the only organisation dealing exclusively with myeloma, which is an incurable blood cancer. The question I ask might be one that you can't answer until January about the New Treatment Fund, but I just wondered if it would be covering how the New Treatment Fund might align with or not the Cancer Development Fund in England, and I'm thinking particularly about drugs that enter the fund under a managed access agreement, and it's a conditional yes under 2 years, Also issues about interim funding. We had a myeloma drug approved this week, which is being funded from the point of approval. And I wondered if the new treatment fund announcements would cover any of those issues.
Well, it could. That again depends on whether we get an access scheme agreed here as well, because part of the challenge has been getting access schemes agreed in the different constituent nations of the UK. And that's meant that there's been different access in different parts of the UK at different points in time. That's really frustrating for individual citizens in different parts of the UK who find out that a drug is available in Wales but not in England, or Scotland but not in Wales. It's really frustrating. It's very hard to explain, particularly to someone who feels this would make a big difference to my life. So it depends on us having the data, being made aware of it, and actually there's part of the interaction that will be really useful to take place about how and where that happens. But, you know, on some of the indications that have already been announced down that process, we've confirmed we funded them. Some of the earliest ones, we've agreed that. So we don't want to see a position where there's a proper evidence base, something being effective, that there is a real time lag in that being available here in Wales, and then we do that on a consistent basis. So that's the ambition, but I can't fly too many kites and hostages to fortune. But if we get that together, and if we're clear that we can do it on the same basis, then we expect the fund to help us to do that.
One last question. See, it's a good way of killing conversation. There we are, sir. Yeah.
Cabinet Secretary Martin Coombs from Novartis. One of the things that we're keen on is getting early engagement with the service and with stakeholders ahead of the point at which we're going to be launching and putting into AWMSG or NICE, essentially to be able to take up the point that you made in your presentation about figuring resource allocation, how we might work together in a joint collaboration in terms of service delivery when the medicine comes along, talking about things like do we have the diagnostics available and ready for when the medicine comes along, to encourage that early access, but also importantly figure where are the data gaps, where are the opportunities to support the NHS allocate appropriate resource, and indeed come to the point at which perhaps we can have outcome-based agreements that help manage the budget impact and the value delivery. I just wonder about your thoughts on that kind of approach, and whether it might be possible to put that into that medicine's introduction pathway at some point.
I'd be very simple to have the earlier engagement and understanding what outcomes will we be able to deliver from something new, what needs to change before that, and how we get agreement on data sharing. I think it's really important, and I think we're trying to signal that that's the sort of conversation we want to have.
Early on, so you're not suddenly pressurised.
And it's how we have that early conversation to make sure that we understand what's coming, rather than a press release saying there's a great new drug that we now want to be available in Wales. Because that puts us into a position where inevitably going to end with conflict at the start. And I think that's quite destructive, because it'll take up time on both sides that'll stop us from having that conversation about what does this mean. If we think that there's going to be data available to show it's effective, who's it effective for, how do we know that, what does that tell us in terms of who that would be within Wales, and what would the service need to be able to do to deliver that, and how can we get that actually out there? Now that's a much more sensible conversation to have. And I still don't think it'd stop individual companies, and I know apart from Novartis, other ones are available. But having a conversation about, well, what do we do? Because if you get to a point where you introduce a new treatment within, then I've never seen that people are unwilling to cover the fact that that's available, what that then means.
Rick, this is the last one, yes?
Cabinet Secretary, it wasn't a question, so I was loath to pick up the microphone, but certainly I'd like to reiterate the ABPI's welcome that we were very pleased to do in your announcement of the new treatment fund over the summer. Certainly everything we've heard since then from you has encouraged us greatly in that welcome, and certainly your consistent approach to the pharmaceutical industry, as you said, in terms of policy and action is very much appreciated. So just to finish off from myself, as an overall thanks for your ongoing commitment and realisation of the benefits that medicines, when appropriately prescribed and with the appropriate evidence base, can bring to the patients of Wales. Thank you very much.
Well, thank you, and thank you for your time. I really appreciate it. And we're looking forward to continuing to work with you closely.
Take care. Thanks very much.